Yeah.
How many of you have a specific place where you store your medications at home, like a cabinet or a drawer? Well, at Los Angeles Christian Health Centers, or LACHC, half of the patients that we serve live in homes like these and do not have the simple privilege of safely storing and accessing their medications. This issue greatly impacts the success of their health management, especially for those patients who also have type 2 diabetes, a condition that is highly reliant on daily medication usage to prevent serious complications or death. Multiple 2019 reports estimate that about 60,000 homeless people currently live in Los Angeles County. If we focus in on the city of LA, there's about 36,000 homeless people. At LACHC, we see 5,000 homeless patients, serving specifically the area within Los Angeles called Skid Row. Additionally, almost half of our homeless patients also suffer from type 2 diabetes. As a warning, the next slide has an image that may be graphic for some viewers. As you can see, diabetic patients are at high risk for severe complications. For example, diabetic vision loss is a significant complication that can be even more dangerous for our homeless patients who are already vulnerable and living on the street. Diabetics also may suffer from severe ulcerations and foot wounds that can lead to hospitalization and limb amputation. Hospital visits make up 30% of the total medical costs of treating diabetes and can cost a single diabetic patient over $4,000 a year. Approximately 100,000 diabetic-related limb amputations are performed per year, and a single amputation can cost the healthcare industry up to $100,000. Loss of a limb has an extremely detrimental effect on patients' overall quality of life, both physically and mentally. We know that separately, homelessness and diabetes are major risk factors for poor health outcomes, but our homeless diabetic patients face a seemingly impossible problem. Diabetic patients often need daily medications, most commonly relying on insulin. Unfortunately, our homeless diabetics lack the safe and proper storage and can mean that their medications are easily lost or stolen. The cost of insulin has tripled in the last 15 years, making it extremely costly to replace for patients and for our medical teams. Additionally, insulin requires the use of a needle. On the streets, there is a stigma or assumption that those using needles are junkies or drug addicts, making our patients easy targets for illegal drug exposure or theft. In addition, our patients are constantly subject to random street cleanups where local law enforcement will strip them of all their belongings without warning. As a result, many of our homeless diabetic patients are forced to abandon their treatment plan, putting them at extreme risk for exacerbating their diabetic complications.
Because of these inherent issues, our patients have inquired about storing their medications at our facility. To answer their expressed needs, we have designed a locker system that will provide a safe and controlled location for homeless patients to store their diabetic medications free of charge. This program provides a space for patients to store their diabetic medication in a secure facility that is easily accessible during our extended hours of our clinic and allow for increased linkage to care to services such as patient education, case management, and social work. Early next year, LACHC is opening a brand new clinic located directly on Skid Row, which will host the lockers and give patients easy access to their medications. In practice, the patient will arrive at the clinic and check in with the nurse at the locker station, where they will be given their unique locker code. Once the patient finds their locker and retrieves their medication, they can then safely and privately administer it to them, and then return it to their locker. They will then return as needed the next day or later that day to take their medication. This 5-minute process alone will alleviate a lot of the barriers that our patients experience when they are forced to carry their medication with them while living on the street. We believe that this program will create a variety of successes among our target population. Overall, we aim to empower our patients and decrease their hospitalization by providing them better access to services and improving their medication adherence and safety. We will harvest our lessons learned so that this program can be expanded to LACHC's other Skid Row sites, replicated using other medications, and shared amongst other community clinics who serve similar patient populations. Our team is asking for $130,000 in order to fund our project and invest in an innovative way to provide better access to vital services. The first step in making this project a reality is an 18-month trial that will allow for multiple medication refill and A1C tests in order to evaluate its progress. The trial will enable our team to maximize our ability to refine and create the most successful version of this project that can be shared and replicated anywhere. With your partnership, we believe that this project can provide better access to the care that our homeless patients need and tangibly improve their daily life and health outcomes. Thank you.
Time?
So the time was 5 minutes and 47 seconds.
Yes.
That is
So-
That's a big
So-
improvement.
Yes, it is.
Big improvements overall. I'm actually very happy to see the movement that's happening. You went on for a long time about the cost complications in diabetes, and then a really long time about amputations. And I thought, folks, like, all you gotta say is, you know, when the picture's up there, diabetes does bad things. It is the number one cause of preventable blindness in the United States. I think that's a bit more impactful than what you say today. It makes your kidneys stop working, makes you have heart attacks and stroke. And that's kind of all you have to say, and that'll be your 45 seconds on the complications of diabetes. I got lost in the numbers, and they really aren't critical to your talk. The critical part to your talk is patients who are homeless, even if they want to take the best care of themselves, just about can't. You know, the bad things that happens when you carry your meds, and it's worse if you need to use insulin because you use a needle. We have a solution. And I think if you just compartmentalize and take out some of that detail, this becomes a very compelling story.
Also on your slide with the ulcer and your vision loss, number one, you said this is going to be a tough slide to see. Then this is the slide that was up for the longest amount of time,
Okay.
right before we go to our break. And I'm thinking,
It's after lunch.
I know, but we're going to the
reception.
reception. After
There's
this.
one more after this.
Oh, okay.
I don't know when you want us to
Okay.
go.
But I think, if you're gonna put this up, say what you need to say and then move on. You don't need to keep this slide up as you're spelling everything out. And also, you started with vision and then you went to ulcers, but most people go from left to right. And so make your talk consistent with the picture that you want me to focus on while you're speaking. So start with the ulcer and then go to vision, or switch your
Or just switch them,
your
and
pictures.
that might actually make it a little easier on the eye too, because then your eye might be drawn first to the less.
Sure.
What's the purpose of the visuals?
The pictures?
Yeah.
I mean,
Is it shock value?
I definitely think it's shock value.
No,
and
is that what you're looking for?
Yeah, because from people that we've spoken with, when I say an ulcer, when I say a wound, they're like, I don't know, that could be
Yeah.
a lot of
As a non-clinical person, I think it's very impactful
Okay, that's
seeing it.
That's the
but-
feedback I'm looking for.
But what I would suggest doing is have your ulcer on the screen, fade it to the vision impairment, fade that out, and then have the text of what the complications are bigger. And that way you won't have it on screen as long, but you'll have the words of what they are. So you can say ulcers, fade to the next one, vision loss, fade to the next one. These are the diabetic complications that, people experience, blah, 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 blah. And that way it's not on screen for too long, and you still get the shock value, which I think is very impactful because, yeah, if you say ulcer, I immediately think like in your stomach. I don't think that.
Okay.
And so if I see that, and I'm like, ooh, yeah, if I were homeless, that would be
Yeah.
really hard to manage.
Okay.
And also, be careful with your joining statements. additionally, in addition,
Mhm.
additionally,
Mhm.
also, in addition, additionally. I think when you were speaking, I counted 5 times you used those terms.
Mhm.
You don't need to put that in, you just say what you need to say.
Yeah.
And then when you transitioned, because you were very deliberate speaker,
Mhm.
you know, you were cadenced and deliberate, and when you picked up, you jumped in, you know, you slowed down.
Mhm.
But when you first jumped in, it was like, whoop, you know, we don't have time, she's gotta finish up quickly, you know, and so she's rushing. So match the two of you and your,
Yeah.
you know, because otherwise I was like, I better listen now because something's happening, you're gonna have to quickly tie up. Cause I felt that you spent a lot of time on this, like Jeff said.
Yeah.
You know, it was just too much on it. And then the other
Did you
thing.
feel rushed?
To me?
Yeah.
Yeah.
when you started?
I think I caught myself being really rushed, and so then I like slowed down.
Yeah, and
Yeah.
I saw it,
But
and I saw it. The other thing was, what's the 130 gonna be spent on?
we're glad you asked that question.
So this is our breakdown slide, and we've gotten mixed messages. If we should keep it here in the appendix and have it available, or if we should have it in the actual picture. We don't have to necessarily talk about it, but we could show the visual.
I think it's a hard slide to read out here. It's very hard to read it, but I think you could just
make the
say it, you know, and 130 will pay for, you know, like,
Operation, I wouldn't say the
You
dollar
could
amounts.
have, well, you
Right.
could also have bubbles just coming out for 130
Yeah.
and just have operations,
Operations,
staff,
yeah.
evaluation, whatever, and just
Yeah.
have your bubbles with the words.
Yeah.
Okay.
because I'm thinking all this is going to buying lockers,
Right.
and it's not. Most
Right.
of this is
Yeah.
going for project staff,
Right.
which, you know, is not even the evaluation.
Yeah.
What are the project staff doing?
Yeah.
So we're
We
gonna-
also have another
We do. All right, so the project staff is gonna be a nurse. So the reason we've picked a nurse is because we feel like it's the safest staff member that we can pilot this project in.
Like
So.
a nurse to supervise the locker dispensing of patients' own medicines?
So they're not just supervising dispensing, right? They're helping them administer their medication if they're not sure how to do that. They're making sure that they have the scope of practice to be in charge of medication dispensing, that not everyone can do that. And they also need to be managing the lockers to make sure if
But
meds
they're
are
not
expired.
dispensing, the medication is in the locker that the patient puts
Yeah.
in themselves, so they're not dispensing it, it's just storage.
Right, but they have to be there we have to have a nurse there in the most safe way, because if the patient has an issue with giving their medication, no one else can administer their medication.
So you need an LVN.
It could be an LVN.
So the cost differential between an RN and LVN is almost 40%.
And look how much we pay.
And,
And that's 100,000, how's that sustainable?
Yeah.
yeah, I mean, I understand what you're saying. I happen to not agree with it, but
Mhm.
I understand what you're saying.
Mhm.
The only way this becomes sustainable is if there's a capital expense, like the lockers and installation, a small maintenance expense, 18% per annum of your of your capital expense, but no dedicated resources to what is a small number of patients. So, there used to be in public health this concept of directly observed therapy, where literally public health folks would go out and
Knock on doors.
give patients their pills
Track them
individually.
Track them down.
Depending upon how many patients you have in this cohort, it would be cheaper to do that than it would be to have a nurse for a small number of patients who's dedicated to this function. And the argument from anyone else would be, well, she can do 10 other things in the clinic. Well, that's great. That's a clinic expense, not a project expense. If I was cynical, I would say somebody at the clinic is trying to figure out a way to get research funding to support an additional nurse, which I'm sure can be used very, very well for lots of good things, but is not what this project is.
Right. And if it is, then, you know, if you need somebody to say, this is part of our trial, our pilot is to identify what the necessary resources are so we can spread. That's different than saying, you know, you're gonna need a nurse to administer this program that you have to pay extra for on top of your operating budget from each clinic, because each clinic is gonna say, I don't have 100,000 to be spending on this.
Right. I think that what I'm trying to communicate, and I obviously did it before Jeff, is that we're trying to do a project that's as safe as we can imagine, because we don't know, I don't think necessarily a nurse has to be there. But to try it out with them, I think we're worried about having anyone, like even if it is an LVN, but if we don't have someone clinical that is helping patients navigate it, and it might not need to stay that way in
But
terms
my
of
question is,
sustainability.
you're doing this during clinic hours. Again, it's not after hours.
Mhm.
The patient, if you can't figure it out, goes in the next door into the clinic. So I'm not sure why you have to have a separate person just dedicated to waiting around to see if someone's gonna knock on the door and may need help. You know, maybe that day they don't come in at all and you've got a person sitting around doing nothing.
Yeah.
So you really have to think about how this is gonna really work.
Yeah.
Tell me if this statement is true or false. The decision or the push to have a nurse was not your decision. It was
It's-
somebody else's.
We've completely planned this ourselves. It was not someone else's decision.
Okay,
Oh,
okay.
okay, I misunderstood that.
Yeah.
So, sorry, quickly, so, one thing I noticed from your presentation is y'all spent a lot of time on the significance of it, and pointed out by that one slide, but you also, that's not the only time you spend significance on it,
Mhm.
and something's not really clicking with me, with the solution. I think it's a fine solution, but, as far as like how you're setting up significance versus the solution, I think you can switch it a little bit, or actually think you should play up what the solution actually is, meaning if this thing goes swimmingly and other clinics that are similar to y'all wanna do a locker system, you know, how does that connect with one of your first slides that says your target population is 5,000, right? So it's kind of like, how is this getting there? You know, I liked how y'all went down from 60,000 to 5,000. I really like that. But something's not really clicking with me with the significance to this particular locker. I actually think the new, world, or like the vision you should be pointing more towards, it's saying like, if we prove that this works, it's not just for these 38 or 40 people, I think, initially, but we really think the system could be easily implemented in not only our other clinics, but in clinics that do our same thing, and I actually think like that's for me, that it would match up more with the story you're telling with how the significance was.
So Taylor did mention that,
Yeah.
but was internal to LA Christian Health Centers.
Right.
Your recommendation would then be to say, this is something to be replicated in other health centers or other.
My recommendation is for it not to be a mention, but like it's for it to be a highlight. Like for you to say like this is our goal, but what we imagine and what we hope for is for it to be for this system to be replicated. You can say like in our other clinics, but like just this is a solution that's going to become a standard of practice for clinics in these popular areas with a high population of homeless people.
Are you guys part of CCA LAC? Okay. What percentage of the total patient base are they? Ballpark? Just 1%?
Yeah, it won't be more than one.
Right. So Susan put it in the context, if this works in our organization, we are just 1% of the patient population represented by CCA LAC. You'll get points from Ms. McCarthy for saying that. And that turns out to be, X number of patients with diabetes, whatever the math works out to. Add LA County Department of Health Services, and you double that number. That's just in LA County, not the rest of the United States. If we prove this works here, it can work anywhere.
And I wonder if one of the things that is sort of a struggle is, how is this different? Because I know when we were talking about lockers a couple times ago, it was, why don't they all just get a mailbox and keep their drugs in it, right? And how is this locker system different than just getting yourself a P.O. box and putting your meds in that P.O. box? And so I kind of hear the urge to differentiate, so the idea of bringing a nurse or somebody, so it's like, look, we're providing this safe space to do it, so you're not just doing it in the post office, right? But then which probably get you kicked out of the post office. But at the same time, I also hear the sustainability end, which is, you know, you'd be better off just paying a guard all night just to have a safe space that was 24 hours, as opposed to paying a nurse who's just sitting there waiting for people to come in. So I think if you guys are still kind of wrestling with what makes this better than a post office, right, but is not a giant burden financially on the hospital, so that it is sustainable and scalable to health centers all over.
I would, think about having somebody on call, since you're doing it during the extended clinic hours anyway, and having a stipend for a person on call to come in and help. And that could be a nurse
Yeah.
on call, but that'll still be a fraction rather than having somebody full-time.
Yeah, I think we need to look at the.
And I think, and this is some little other stuff, the vision slide that you have, it was so less impactful than a lot of the leading up slides. I wasn't nuts about the road graphic, but you're like sort of, here's short term, here's medium term, here's long term, which is, and they're all really important concepts, but I was just kind of like, there are no graphics, there's no pictures, so I wanted to spend a little bit more time and have a little bit more like emphasis on those, because it was almost kind of like what you're saying, a little bit of a letdown where I'm like, okay, like, and on the maps, I like the maps. Can you go to one of the map slides, please? So I was a little like disoriented on this. So are the stars where the clinics are? So maybe put your logo instead of a star. And then if you're able to highlight Skid Row in a different color, because you guys are directly on Skid Row.
I think
That's
they're,
good.
Or
so I think that they're defining
Skid Row is the red area.
Skid as the whole red area.
So label it.
Okay, yeah, we did it here. We can
Yeah,
look at it.
it's still, because I know it's not just one street, but like conceptually I'm like, okay, this is a geographic area.
Well, for some people, Skid Row is one street.
Yeah.
So people, I don't know if there's an official definition of Skid Row. Does anybody?
There is.
Yeah.
And is it the geography in that outline, or is it?
That's
Okay.
Yeah.
Okay.
So just,
Then you are labeling it correctly.
yeah, it just, maybe in how you described it or something, because I'm like, it's a street. Or, like just, it didn't sink in as much. So I definitely do the logo, like the heart logo, rather than a star,
I get what you're saying. No.
to show like, here's where our clinic is.
Skid Row is bigger than a street.
Yes.
And we have 5 locations.
I didn't realize
Within
people
the
thought it was a street, so.
Yeah.
Oh, yeah.
Yeah.
Because you're in there, right?
Yeah.
It's 18 blocks.
I didn't,
18
yeah.
Yeah.
block area.
Yeah.
You can even say that.
Like,
It's
yeah,
block
talk
area.
about how big an area it is, and we're smack in the middle of it. Here we are. Here's where it is. Just kind of emphasizing that a bit more. And then when you were talking about some of the data collection, it sounded, because you were going a little fast on this part. You mentioned collecting some extra money to collect data, so like A1C. Some of the stuff I'm like, these are usual care data elements, things that the clinic already would be collecting. So I don't know if you're collecting, and somebody clinical can correct me too if I'm wrong, but I don't think you're supposed to collect, collecting A1C more frequently isn't going to necessarily tell you
Right, we're
more
not
of a
saying
change.
that at all.
Yeah, because this to me, I heard this and I was like, oh, wait a minute, are you collecting money to collect stuff you're already collecting? Like, that's not a good use of money. So just, I just be careful how you phrase it.
Sure.
Because I was just kind of like, you don't need money to collect usual care stuff. But yeah, so on this slide, I think, like, losing the road, having some more bubble, something where I'm just kind of like, because it's kind of getting lost, because there's a lot of stuff.
People in the audience can remember no more than 3 things.
Yeah, there's
There's too
just,
Okay.
yeah, there's
So
just
what
too
are-
much
What are
here.
the most important things you're changing?
Okay.
No, I want the answers.
I mean, I think the biggest short term is seeing better med adherence for those patients. The midterm is that they're gonna see their A1Cs go down. And then the long term is probably the harvesting the lessons to share with other people would be our hope, is to, be able to expand it.
That's mixed. Those
Yeah.
are mixed. Some are patient-oriented, some are, so,
I think improved health outcomes, so your bubbles can just be like improved health outcomes. For me, one of the big things when you first did this presentation was the needle stigmatization.
Right.
safety, so.
And safety and increasing safety, decreasing stigmatization. And so better health outcomes, increased safety, decreased stigmatization, expansion to other sites. Like, those are your main points. This is great for like the tabletop, for like getting into the weeds of it.
Okay.
But I think, yeah, there's not enough to focus on, and so if you really trim it down, then you're able to sort of punch on those a little bit more. Yeah.
And also, this whole project is just for 38 patients out of your 5,000?
Wait,
So
say it again?
5,000 is our homeless population. Half of that is also diabetic, so it's 2,500.
And you're only doing this for 38 patients?
Yes, that would be the project.
You gotta cut down your budget.
Yeah,
Okay.
because, so you're doing this for 38 patients because you have 38 lockers?
Well, the company that we looked at, that's how it's built
Is this
out.
the refrigerated ones?
No, we took that out.
So have you looked at Amazon lockers?
Like the brand.
Yeah, so if you've not seen them all around town, I think Amazon already has a locker that fits your needs perfectly. And you consider, and some of them are actually in drugstores.
Those are for Amazon products, right?
Right, but figure out who made those.
Who made, yeah, so
Yeah,
their supplier was.
So figure out who the supply
Okay, okay.
chain is of the Amazon locker.
Yeah.
And that's for later.
Okay.
Yeah, I mean, if that really works, then there's a bigger discussion with Amazon, not about paying their taxes, but
Mhm.
about giving back to the community directly.
Quick
But-
question. Sorry, so Kat, correct me if I'm wrong, but initially your ask was like in the 20K range, and then I think you guys were encouraged to like go a little bigger, try to go for 100K. So maybe kind of go back to something that you were originally intending to. If you can
Think
get in
about the,
50K range. I think
yeah,
it's
think about the per
probably
capita,
better.
like the
Exactly.
yeah.
Exactly.
The money per patient.
Because I didn't
Yeah.
even
Yeah.
I didn't
realize.
realize there's 40 people.
I didn't realize until someone said, can you move back on the slide, and I caught it going backwards, and I said, wait. You've got how many thousands of people who are diabetic on Skid Row, and I understand it's a pilot, but you're just spending how much money on 38 people?
Yeah, I mean, because if you can get it like 50, that's something somebody could easily act on to help with a pilot, as opposed to 100. But that would be.
Well, again,
That's-
but the budget has to fit a vision that shows that it's safe, effective, and scalable.
And it has to be real.
Yeah.
It can't be, well, we think this should be the way it is. You have to really know that this is the way it should be. So you probably need to speak with someone about what's realistic.
Yeah. I would talk to your clinic about the on-call idea, and I'm mentioning that
Laura,
just, yeah.
I just forget any extra staffing.
Yeah.
Okay.
Forget on-call to help a patient.
Mhm.
If they
Just send them
don't know how to
inside.
take their meds,
They just go with some.
They go into the clinic.
Because you're trying to just replace the idea that people are on the street doing it anyway, and they're gonna get their meds stolen, so you're just trying to give them a place
Remember the
to
scope
store
of
their
what you're
meds.
fixing.
If you had 100 lockers and $50,000, it's still $500 a person, right?
Mhm.
So, for a pilot, ooh, right? But if you can get it down even more, right, because you could make an argument that, well, we want to evaluate the data, bring up those evaluation costs as an evaluator, for what you really want to evaluate. And then,
Again, it's a one-time capital investment. And then it's, since it's in the clinic, if they have any problems, they just go in the clinic for help on, they're out of the medication, they don't have enough of medication, they don't have insulin medication, they're out of the needle, somehow it's not, also, who's putting the stuff in the lockers? At one point you said it was gonna be people in the clinic that was gonna fill the lockers with all the necessary medications, needles and everything like that.
You can't do that legally.
Right,
Yeah,
and
it's-
so, because you were gonna have the pharmacist could put it in for them, but I didn't hear that now, so if the patient's gonna be carrying it around the clinic, or through the clinic to put it in after they fill it at the pharmacy.
so that actually begs the
This
question.
is actually gonna be right next to the pharmacy.
So actually, that begs the question to your staffing point. How do they get assigned a locker?
Right.
So if I want one of these lockers, who's assigning the locker and who's keeping track of who's in what locker? And how do I know they started a locker? How do I know when they end having the locker? Do they have the locker forever? You don't need to answer all those questions in your slide presentation, but have them in the back of your mind. But that could also help answer some questions around stipends for staffing. Not that we want to add in too much staffing, but I agree that you can't just have lockers with nobody, because then how do you get one, right? So somebody does have to be sort of manning in the background.
Also, keeping other materials in the locker. So is anybody gonna do a check to make sure that
No guns.
there are no weapons, there are no illegal
Alcohol.
drugs, alcohol, whatever, stored in the locker?
So you mentioned in the beginning about ulcers. So patients with ulcers, maybe they could also store their supplies because they get gauze, they get so many things. And you also mentioned about nursing. So if you're thinking of staffing a nurse, maybe they could help with wound care.
Right. I mean, I think to us, it made a lot of sense to have a nurse, maybe it's part-time, whatever, tied to the lockers. I don't think that, in our vision, it's not gonna work for our clinic to just expect any nurse at any time to be on call for that locker. We have to have someone that's part of their role.
But what are the clinic hours?
We open we can let it at 6:30 or 7, and then.
We open our doors at 6.
And close at
5.
So you have a 12-hour, basically 11-hour shift that you're gonna have somebody sitting around waiting for someone to come in and use the locker. Every day that the clinic's open. So that's 5 days a week or 6
5
days a week? 5 days. So what do these people do on the weekends to get their insulin?
Especially if it's been locked up on Friday and they forgot to get it out.
So, I guess in the beginning, in the previous, what I thought about is those banks, they have the ATMs where, they have it locked up, but, you want to have a guard there. Because if it's a homeless person, they have access to it, they could sleep there, it probably won't be that safe. So, it's something, I don't know, I
Yeah.
thought about when I heard you guys wanted to do that.
Yeah, we thought about a guard. We thought about how it could be accessible outside of clinic hours.
Mhm.
Again,
You have to have it accessible outside of clinic hours. It
Yes.
has to be, because if you're training people to come there for their medication, and this is a daily medication, they have to be there every day, they have to access it every day. Otherwise, you're teaching them, you only take your insulin 5 days a week.
And during their
Or
times.
you have to get there before clinic closing to take it out, where you're breaking your safety rule that they can be then mugged on the street for their needles. So clinically, you have to be thinking about what are the patient needs, specifically for patients who need daily medication. And then, you know, then how you're gonna operate that, you know, or make that real.
So, I think about, because these are the kind of questions that judges are gonna ask.
I mean, I loved your presentation, but when we
Yeah.
start to get into some of the
Like the
realities
yeah.
of the things that our funder might be asking, these are the kinds of things they're gonna say, this isn't completely thought through yet.
So have you talked to leadership at your clinic about this? So have you talked with them about the possibility of doing like an in-kind of some staff time towards it, or not like 100%? So that might be something, that would be something that would strengthen the pitch. You know, saying like, we know that we do need to have some staff working on this. The clinic is willing, you know, has offered to donate such and such amount of a person's time or effort in kind, because they know that it's an investment in our patient, you know, that kind of thing. And it kind of solidifies that the clinic's on board with it. So, and you can also just say, well, you can go two directions. You can say, we're building a new site, so this is the time to get it built in so we can build access to it for after hours, but we need to act soon. Or you can go the route of, this is a pilot to determine if this is a good solution. If it is, then we will continue to work to make sure that it's available 24 hours, 7 days a week. So you can go one of those two routes, because you are presenting it as a pilot.
But then I would, if you're gonna present it as such, that in this pilot, you know, it's a
Yeah.
proof of concept. We can only do it during clinic hours, so we will be ensuring that patients take their medication with them for the weekends or something, so that you've thought it through.
Right.
So that you know, funder says, okay, they've already, you know,
You've
identified
thought
where
about
their
it.
pitfalls are, but they recognize it's a pilot, proof of concept, and this is their workaround.
Yeah, and that might be the best direction to go in. And I would guess if you mention it during the pitch, you'll avoid that question and digging too much into it in the Q&A section.
But you have to have a solution that's viable. And I don't know that, you know, if the patient is homeless and they don't get to the clinic on Friday, then they're without their insulin until they can get to the clinic, maybe Monday, and what if something happens and it's not, then it's Tuesday.
Then can they sue the hospital?
Yeah, I mean, because they have the medication, but it was locked up and they couldn't get in. You know, what if they're banging on the door, I need my insulin, where do they go, what do they do? Is there a button that they can press that someone will come and come down and, you know, I mean, I don't know, but, you know, insulin is a tricky thing.
So it's not to say, so it's, overall, this is a really good presentation. So I don't want you guys to feel like we're shitting on you for it. Like, it's a really good presentation and it's a really cool idea. And because it's cool and interesting, that's where we're like, well, what about this? Because we're nerds and we kind of get excited about doing that sort of thing.
Well, we're clinicians also.
Yeah.
I mean, clinically,
It's problem solving.
It's also it's problem creating. Because
Yeah.
if the patient carries their insulin with them, then they have access to it all the time, as long as they don't get mugged or get stolen or something. But if you're asking them to give up their medication to a locked facility that they don't have access to, I don't know, you know, what that means legally even. You know, I don't know what it means in terms of health consequences in an already known unreliable population.
And when we ask ourselves questions like this, you know, and try to think as a group and come up with these challenges, it kind of forces us to come up with even better solutions, you know. And so that's, you know, even after we did our pitch last year for the phone app, it was lovely in theory. We piloted a version of it, but we've had a technology advisory committee now for about a year, and boy, did they ask us some questions that we did not know the answers to, right? It was like, ew, I don't know. We hadn't really thought of that, and that really forced us to go back and revise and revise and revise. And we're at a place now where we have a way better product, right? So, I mean, I think that's you know, the beauty of this process.
So
is being able to reflect.
I would suggest taking, because you look at the report, you know, take some of the questions that we're asking you to your clinic leadership too, and say, you know, these are some of the challenges we're facing. Are there some infrastructure or things that the clinic has that we're not aware of that might be able to help mitigate some of these concerns? And see what they suggest too, you know, because you guys know your site better than we do.
Yeah.
So see what they recommend to you. And it's just like, it's not to freak you out, but these are some of the questions that will be asked, because it is a very novel idea. So it is kind of like, oh, cool, so like, if we did this, what would it, it's new and it's kind of interesting, so I don't want you to feel negative about the questions we're asking, but just start really thinking through and getting some canned answers kind of ready to show that you've thought about it already.
Definitely don't feel negative.
Yeah.
Yeah. No, it's so improved, it's great.
Yeah.
But, I think like Laura said, if you have answers, even if they're not great solutions, but it means you thought it through, I think that's very key.
Yeah.
Great presentation.
Yeah.